Welcome to the first episode of Striking a Balance Between Effectiveness and Heart Health. Today, we're laying the foundation for understanding BTK inhibitors, what they are, how they work, and why they've transformed the landscape of chronic lymphocytic leukemia treatment. Listen as Anacita Fadal, PhD, APRN, from MD Anderson Cancer Center, and Amy Goodrich, MSN, CRNP, from Johns Hopkins Kimmel Cancer Institute, two distinguished experts in hematology and oncology nursing, discuss critical insights into the clinical profiles of various BTK inhibitors, long-term data, and their impact on patient outcomes.
Hello, I'm Anacita Fadal, and today I'm joined by my esteemed colleague, Amy Goodrich. Amy, could you please tell us what is CLL and what is its prevalence in the United States?
Sure. So CLL, or chronic lymphocytic leukemia, is a chronic B-cell malignancy. It is characterized by the clonal proliferation of mature lymphocytes. And the requirement for the diagnosis of CLL is an absolute lymphocyte count of at least 5,000 or 5 times 10 to the ninth per liter lymphocytes in a CBC with differential. And then when you do peripheral blood flow cytometry, which is the most common diagnostic tool, CLL will express CD5, CD19, and CD23. CLL is the most common type of leukemia, and in 2025, there are an estimated over 23,000 new cases that we anticipate being diagnosed in the United States. And even though it is the most common type of leukemia in the United States, it does only account for 1.2% of all new malignancy diagnoses. And then the prevalence in the United States, based on 2022 data, is estimated that 226,000 people are living with CLL. So even though it is a relatively small number of people being diagnosed, all of these therapies are certainly leading to more and more people living with this disease.
Thank you, Amy, for that background on CLL. It is a very common type of leukemia, as you said, and it's very important what we need to manage, to know what to manage with these patients. So, what are the BTK inhibitors, and what is their role in the treatment of CLL?
That's a great question. So to understand why BTK inhibitors are so important, it's critical to understand the B-cell receptor signaling pathway, which BTK is part of. So the B-cell receptor signaling pathway is responsible for all of the signaling related to the survival, the proliferation, the differentiation of those lymphocytes. And our BTK inhibitors, or Bruton's tyrosine kinase inhibitors, target BTK, which is a cytoplasmic tyrosine kinase that is an essential part of this B-cell receptor signaling pathway and responsible for survival, proliferation, all those things related to our lymphocytes. And what happens in CLL is BTK becomes overactive, and it drives the proliferation of B cells and allows for the development and progression of CLL. So it's really a perfect target for our BTK inhibitors. And so what they do is they block that BTK signaling and help prevent the abnormal proliferation of those B cells, or those, the B cell lymphocytes. And so what are our BTK inhibitors? So we have a growing number of BTK inhibitors that are available and approved by the FDA. They are first line and relapsed refractory, indicated in our NCCN guidelines. They are continuous oral therapies. So these are treatments that patients take for as long as they're working and as long as they are tolerating them. So they're really a great option for our patients with CLL.
Amy, thank you for that insightful information about BTK inhibitors. It surely is very helpful for clinicians involved in the management of patients treated with BTK inhibitors. So, what are the guidelines for the use of BTKs for CLL?
historically, we had been used to our best risk patients, our good risk patients with 13q deletions, or our average risk patients with trisomy 12 or normal fish findings, having different recommendations than our patients with deletions of 17p or TP53 mutations, which are our highest risk patients. But what BTK inhibitors did was they really leveled the playing field. And so if you look at the NCCN guidelines, regardless of those risk factors, regardless of their prognostic findings, BTK inhibitors are indicated for first-line therapy, some with optionally with a anti-CD20 monoclonal antibody, some without. And so the recommendations are a covalent BTK inhibitor or venetoclax with obinutuzumab. And the guidelines do a really good job of lining out if you start a drug and patients are not tolerating it, you can move to another covalent BTK inhibitor as well. If patients are having tolerance issues. And then it's the same for relapsed refractory, that if they have not had a covalent BTK inhibitor, so something like ibrutinib, acalabrutinib, zanubrutinib, as first-line therapy, then those are indicated as second-line. So they're really widely used in the CLL population at this point.
So, what are the differences between the first, second, and third generation of BTK inhibitors?
It's basically side effects, but we're going to go through some of this. And so cardiovascular risk is really the driving factor here. So our first generation BTK inhibitor, ibrutinib, had the most off-target effects, so was the least specific for BTK, and so had the most side effects because of those off-target kinase inhibitions. And so since ibrutinib, our second generation covalent BTK inhibitors are acalabrutinib and zanubrutinib, and what has happened with them is they have a higher specificity for BTK, so fewer off-target effects, and then thus fewer side effects. And we're going to talk a little bit about efficacy in a bit, but they do all have very good efficacy. And so really, as each iteration of these drugs has come to market, they've had less side effects because of less off-target effects. And now we have the third generation pirtobrutinib, which is a non-covalent BTK inhibitor that has the highest selectivity to BTK and the fewest off-target effects. So that is also another option for our patients, although currently in the FDA label, patients must have had a covalent BTK inhibitor and a BCL2 inhibitor, so venetoclax, so something like acalabrutinib or zanubrutinib and venetoclax for pirtobrutinib to be indicated. But again, this is another great option for our patients who have already had a covalent BTK inhibitor.
Amy, thank you so much for discussing, the different actions of these BTK inhibitors. And, I would like to ask, what are the clinical profiles of the BTKs that are approved to treat CLL? And what do the latest clinical trial tell us? And why should we pick one BTK inhibitors over another?
Sure. So we have a number of trials. We have Resonate 2, we have Elevate Relapse Refractory, we've got Alpine, we have Bruin. Those are the main trials that I'm going to talk about. And although there are a lot of overlapping side effects, there are distinctions between these agents as well. So again, we talked about acalabrutinib being our first generation BTK inhibitor with the broadest kinase inhibition. So again, it works very well in the upfront therapy, in the relapse refractory setting as well, in high-risk patients, in good-risk patients. But the notable off-target toxicities are atrial fibrillation, hypertension, bleeding. And long-term data does show very durable responses, but many patients end up discontinuing due to adverse events. And thus, ibrutinib is no longer a preferred agent in our NCCN guidelines. The preferred agents are acalabrutinib and zanubrutinib, which are our second generation BTK inhibitors. And so with acalabrutinib, it's a covalent BTK inhibitor. Again, more selectivity for BTK, fewer off-target effects. And we've got a randomized trial that randomized patients to ibrutinib or acalabrutinib. And the efficacy was equal, but acalabrutinib had a lower incidence of atrial fibrillation and other cardiovascular events. The common adverse event, the unique one with acalabrutinib, is headache. All BTK inhibitors can cause diarrhea, infections, but again, improved tolerability with acalabrutinib versus ibrutinib and fewer treatment discontinuations with acalabrutinib. And then if we move on to zanubrutinib, again, this is another second generation covalent BTK inhibitor, and the Alpine trial randomized patients to ibrutinib or zanubrutinib. And the unique finding was that zanubrutinib had superior progression-free survival and overall survival when compared to ibrutinib. And like with acalabrutinib, it did have a lower incidence of atrial fibrillation when compared to ibrutinib and also had lower cardiac events. So again, our second generation zanubrutinib had favorable efficacy and improved safety. Also compared to acalabrutinib in a meta-analysis in high-risk CLL patients. So when you compare it to ibrutinib, it has improved progression-free survival and overall survival when you compare it to zanubrutinib. But again, this was not a randomized trial. This was a meta-analysis. It did show favorable efficacy when compared to acalabrutinib. And again, our second generation agents are more well-tolerated and have less discontinuations due to toxicity. Pirtobrutinib, which I mentioned a minute ago, is our third-generation non-covalent BTK inhibitor. And so the real benefit to pirtobrutinib is that when the covalent BTK inhibitors bind to BTK, they all bind in the same place. And when that binding pocket mutates, all of our covalent BTK inhibitors will, the disease will be resistant to all of them. So if it's resistant to one covalent BTK inhibitor, it will be resistant to all of them. Pirtobrutinib binds to BTK in a totally different place. So if patients have progressed through a covalent BTK inhibitor, they can respond to pirtobrutinib because it binds differently. In addition, because of it being our third generation drug, it has the best safety profile. It has the lowest off-target effects, so the lowest rates of atrial fibrillation and hypertension. And in terms of response rates, it has high response rates and a median progression-free survival of approximately 20 months. And if you look at the NCCN guidelines, it recommends pirtobrutinib after a covalent BTK inhibitor and a BCL2 inhibitor, so venetoclax. So most patients are getting pirtobrutinib third line or beyond. The most common side effects with pirtobrutinib that are notable: infections and cytopenias, and those are also issues with the other agents as well, but low rates of cardiovascular toxicity. And so again, acalabrutinib and zanubrutinib have improved safety with either comparable or superior efficacy when compared to ibrutinib. And then our pirtobrutinib, our third generation non-covalent BTK inhibitor, really provides a great option for patients who are resistant or intolerant to our covalent BTK inhibitors. Again, we've got a number of agents here, and so treatment selection has to be individualized based on the patient's risk profile, their prior therapies, their comorbidities. And one of the most prevalent off-target effects of BTK inhibitors that is really felt to be a class effect and not as well as an off-target effect is bleeding, this increased risk of bleeding that is really quite poorly understood, but that is seen with all of our BTK inhibitors.
Amy, thank you so much for the comprehensive discussion of the different types of the BTK and the potential adverse cardiovascular effects of these BTK inhibitors. So, how is this information applicable in practice?
Well, I think to talk about application in practice, let's talk about a case. And so this is a lady who is 64 years old. She's had CLL for a number of years. She has normal fish, so a very average prognosis. Her IGHV status, which we've not talked about, was mutated. So she has very normal risk, average risk CLL. And we had been watching her lymphocyte count go up, and she was starting to become more fatigued. And over the course of about a 6-month period, we were talking to her about treatment options and talking about a covalent BTK inhibitor being given until progression or intolerance versus venetoclax with obinutuzumab, which is a 1-year therapy but involves infusions and tumor lysis monitoring. And so she's an otherwise healthy person on no meds, normal blood pressure. So thinking about our BTK inhibitors, she did not have any cardiovascular risks, didn't have a history of AFib, not on any antiplatelet or anticoagulation. And she works full time and she wanted to continue to work full time. And so, although the finite therapy option with venetoclax and obinutuzumab was attractive, she ultimately decided that she wanted a BTK inhibitor because there were less visits, there was going to be less interruption to her work schedule. And so we started her on acalabrutinib, 100 milligrams twice a day. We did go over all of the data with her. She knew she wanted a second generation BTK inhibitor, and she just decided that we had more long-term follow-up with acalabrutinib than zanubrutinib. And, I think this is where us educating patients is so important because we rely on them to take these medications, and the more involved they are and the more of that shared decision making that we can engage in, the happier and the more adherent our patients are to these regimens.
Thank you so much. Like with all these, like the discussion, your comprehensive discussion is really excellent. So, what are the key takeaways that we can, like as a clinician, could take from your short presentation on these BTK inhibitors?
Sure. So BTK inhibitors are here and they're here to stay. They're indicated in all lines of therapy for CLL. We now have our second and third generation BTK inhibitors that are more well tolerated because of fewer off-target effects. In those head-to-head trials with ibrutinib, both acalabrutinib and zanubrutinib showed improved safety and comparable or superior efficacy. And then now we have pirtobrutinib, which is an option for our patients who have become intolerant to or resistant to our covalent BTK inhibitors. So it's really an exciting time for our patients with CLL to have so many truly effective options.
Amy, thank you so much for sharing your expertise and your comprehensive discussion of the role of BTK's inhibitors in the management of CLL. As I've noticed in clinical, there's not as many atrial fibrillation that I've seen in the clinical setting with the use of the second and third generation BTK inhibitors. I'm hoping that these extensive explanation or discussion would be able to help the clinicians in managing their patients. Thank you again, Amy.
Thanks for having me.
If you want more education on BTK inhibitors, visit the ICOS website at www.ic-os.org or the France Foundation education page at www.francefoundation.com/education. This resource was developed by leading experts from ICOS and the France Foundation to support providers and patient care. Tune in to other episodes in this podcast series, where experts discuss cardiovascular risks with BTK inhibitors, as well as assessing and managing risk in patients with CLL.